Okay, class, I just wanted to do a quick recording of some of the things that I feel are pretty important when you go into your labor experience and, of course, for your exam and understanding as well. I went over these things pretty fast and they're kind of confusing in their own right, so I felt like I needed to slow down and review these things with you. And the two things I am going to review with you are fetal position and the fetal heart rate tracings and things like that. So as far as fetal position is concerned, we talk about the right or left side of the mom's body, and if and that's designated R for right, L for left. You can understand that. But if it's central or in the center, we don't say center. We just don't designate anything. Okay, it's assumed. Okay. Then we talk about the landmark. What are we feeling? What part of the presenting part of the baby are we feeling? There's the occiput, which is basically the head, the back of the head. There's the mentum, which is basically the face or the chin. The sacrum, which is the baby's butt, of course. And then the scapula, which they call the acromion, and they designate that as an A. Okay, and then they determine what part of mom's body is it facing? The front of mom's body, the back of mom's body, or is it transverse? Okay, so the front of mom's body is called the anterior, or A. The back of mom's body is posterior, P, and transverse is a T, of course. So let's describe this a little further. So when you're doing the vag exam and you're feeling the part of the baby's body, so if you feel a sacrum, first of all, then that baby is breech. You really don't need to determine if it's anterior, posterior, transverse, right, left, wherever it is. It's a sacrum. It doesn't need to be, that woman doesn't need to be laboring with a breech. A sacrum is a breech presentation, okay? And she doesn't need to be laboring, okay? If you feel a scapula, then baby is probably transverse in there, okay, and that cannot be delivered vaginally. Now, with that being said, and the mentum, the face, that would be a pretty difficult vaginal delivery if it would happen at all. I've never seen a face delivery, but stranger things have happened. So, with that being said, if she's a sacrum presentation, it doesn't matter right, left, anterior, posterior. You need to call your doctor and say, I have a breech presentation. Okay, we need to deliver her by cesarean. If you have a mentum or a scapula presentation, it is possible that the physician can come in and do a vag exam and try to reposition that baby a little bit, so that baby is now head down. Now, that being said, that's called an external version. Those things are not very successful when the woman is term, and especially when she's in labor. So when they know a baby is not head down, and if they know that by 36 or 37 weeks, they can bring that woman in and try to turn that baby so that baby is indeed head down, and she can continue with her pregnancy until she goes into labor and hopefully have a vaginal delivery. Okay, so when we are documenting and when we are talking with other healthcare members of the team, we are really, and this woman is progressing in labor, we're assuming that this baby is head down. Not assuming, we're going to check and know this baby is head down. So throughout this woman's labor, we're talking about this baby being head down. Okay. Well, what part of the head are we feeling? Which way is it facing? That's important because it will impact her length of labor, and it will impact her length of pushing, and it will tell us how strong she needs to push. Okay, so when you feel the baby's head and you're saying, yes, this baby is head down, it's occiput that I'm feeling, we want to know where that occiput is facing. So that is the back of the baby's head, okay, occiput. If that is facing forward or towards the front of mom's body, then that baby is anterior. So we would say, hey doc, this baby is OA. He immediately knows that the baby is one head down, and that the occiput is facing to the front of the woman's body, and that's great. Okay, we don't anticipate much problems with that presentation. And if the baby's occiput is OA, but maybe it's facing a little bit to the woman's right or a little bit to the woman's left, we can say, hey doc, baby is ROA or LOA, which is not really any big deal. That's great. Baby can be delivered that way. Now, if we're feeling the occiput, but we're feeling it towards the back of the woman's body, then we would designate that as occiput O, posterior P. OP, hey doc, this woman is OP. And right off the bat, we're going to know, oh my goodness, so the labor may be longer, and then the pushing may be longer and harder. She's going to have to push harder with an OP presentation. Now, the OP may be a little to the right or a little to the left, so we would say ROP, LOP, okay? Now, if the woman progresses and pushes and delivers that head, despite where it is, that doc may turn that baby's head or the occiput in a transverse position. So the head is delivered and he kind of turns it. Okay, so the occiput is now transverse. It's either transverse to the right or transverse to the left. Okay, and the reason why he does that is to facilitate the delivery of the shoulders. Okay, so the front of the woman's pelvis or the pubic bone is higher than the posterior part of her pelvis. Okay, so we can deliver that top shoulder first, and then let the bottom shoulder deliver second, and then pull baby up to the belly. So that you'll see that demonstrated when you get to view a delivery. Hopefully you all get to view a delivery. So I want to go to this next slide and kind of show you what those positions look like. Okay. So an ROA, the first picture here, is the occiput of the baby is facing to mom's right, and it's anterior. You can see this is her pubis, and back here is her sacrum and coccyx. Okay, so the occiput, the back of the baby's head, is anterior, facing her front, but it's a little on the right. Okay, here it's completely transverse. The occiput is completely transverse. Okay. So it's really facing the right. It's really on the right. Okay, that's going to be a difficult delivery, but it can happen. Not as easy as just a straight OA. Okay, now here it's ROP. So the occiput, you can't really, so this is the baby's face right here. Okay, it's kind of hidden down here, but the occiput, the back of the baby's head, is right here, and it's facing the back of the woman. So it's a posterior presentation, and it is kind of facing the right of her. Okay, so it's an ROP. That is going to be a difficult delivery for her. Okay, she's going to have to push real hard. Here in the second row, we have LOA. So the occiput is facing the left, or is to the left side of the woman, facing her anterior or the front of her body. So that's a good position to be in. OA, anything with OA is really good. Just a plain OA is the best, but ROA, LOA, they can be delivered. Okay. Now here's an LOT. The occiput of the baby, the back of the baby's head, is facing the left of the woman's body, and it's completely transverse. Okay, so here is LOP. Again, the occiput, the back of the baby's head, is leaning towards the left of the woman's body, and it's posterior. It's facing the back of her body. So this is going to be a difficult delivery. And here, I'm not going to spell these out to you, but you get the gist. Here is the face presentations. They designate that as mentum as an M. Okay? These are actually kind of rare. And so maybe your physician can push that baby up and tilt that head down a little bit. I don't know. You'll just have to see. And then here are your sacral presentations. These are breech. Okay? So I hope that was a little better explanation for you, not so quick. If you have any questions, please email me or call me. Okay? The next thing we're going to review, I'm going to go through this a little slower here. I ran through it like crazy, and I felt really bad about that. So I want to go through this a little better. So we're talking about the fetal heart rate baseline. Okay, a normal baseline for the fetal heart rate is 110 to 160. Anything less than 110 is bradycardia. Anything over 160 is tachycardia. Now, we need to look at a 10-minute segment of the strip. Okay? Now, in that 10 minutes, we need a continuous, at least 2 minutes of continuous tracing periodically through that 10 minutes. Now, normally, you have a continuous 10-minute tracing, but sometimes if mom's moving, if baby's moving, we lose the recording or the tracing of the baby's heart rate. Okay, so we can't look at a 10-minute strip that has less than 2 minutes of continuous tracing and say, hey, here's the heart rate. We don't know that that's the heart rate. So we need kind of 10 minutes. If you don't have 10 minutes, or you don't have a continuous 2-minute tracing within that 10-minute period you're looking, then look at another 10 minutes. Find a 10 minutes where you have continuous tracing, okay? And if you're having a tracing where you're not getting good tracings, you have all these breaks in the tracing, you need to be in the room readjusting that monitor so that you have a better tracing of the baby. Okay, now, that being said, so we look at the 10-minute tracing, we average the baseline, we look at the average of the heart rate baseline, and that is when we write that in our charting, we won't put like 110 to 130 is the baseline. We will put one number, and so that's why you kind of want the average. If you drew a line through the middle of that baby's heart rate tracing, where would that line you drew be? Would it be 135 or would it be 130? Okay, so that's how we determine baseline. Okay. Now, after we look at baseline, we want to look at variability. We want to determine variability. Those are the beat-to-beat variations in that heart rate. So you have all this squiggly line on your tracing. And we categorize variability in the absent, minimal, moderate, marked that I told you. Now, variability tells us if our baby is oxygenated, okay? So that's why we want to know what variability is on this baby. If your line of variability, your fluctuations in those variations in the heart rate, if they're undetectable, if it's like a flat line, then your variability is absent. So you would say, my baseline heart rate is 110 with absent variability, okay? Absent variability means your baby is not oxygenated and it needs intervention. If you determine that your variability is minimal, that means that the baby has less than a 5-beat fluctuation in the amplitude of the heart rate tracing, then your variability is minimal. Now, you can say your baby is not well oxygenated with minimal variability, and that would be correct unless your baby is in a sleep pattern, and when your baby's in a sleep pattern, it's quiet, there's not a lot of fluctuations in the heart rate, baby's just kind of sleeping, okay? So that's not a bad thing, but you need to do some assessments to see, or you need to reassess often to see that that variability is coming back to normal. Then your next one is, so then you would say my baby's heart rate baseline is 110 with minimal variability, okay? Now, if your variability is 6 to 25 beats, there's all these fluctuations. You look at the paper, you measure, yeah, like it's at least 6, it's more than 6, and it's less than 25. That's all going on through your strip. Then you would say your baby has moderate variability. My baby's heart rate is 120 with moderate variability. And that means your baby is oxygenated. That's great, okay? The next one is marked variability. So that's more than 25 beats between those fluctuations. And that is not a great thing. Your baby is telling you, hey, like I'm struggling here. I'm trying really hard to make my life better and I need your help. Okay, so marked variability needs intervention. Then the next thing we're going to determine about our baby's heart rate is, do we have accelerations? Now, I did say in class that if you have a sick baby, you don't have accelerations. Sick babies don't want to move around. They want to try to keep everything really stable and quiet because they don't have a lot of stores, a lot of backup. They're sick, they're not feeling well, they don't want to be doing much, okay? So you're not going to see acceleration, so you're going to be concerned about that baby. Now, when we look at accelerations on the greater than 32 weeks, we want to see a baby that's greater than 32 weeks gestation. We want to see that baby having accelerations that are 15 beats above its baseline that last at least 15 seconds, okay? And less than 2 minutes, okay? So if it's greater than 2 minutes, we'll talk about that. But a very active baby, very well indeed, may have accelerations that are greater than 2 minutes, and that's okay too. We'll talk about that. But we want to see normal accelerations are 15 beats above the baseline for at least 15 seconds. Now, I'm throwing this in there. If your baby is 28 to 32 weeks or less than 32 weeks, we want to see accelerations 10 beats above the baseline for at least 10 seconds. Now, at some point, less than 28 weeks, you know, there's a 26 to 28 week deal there where some babies can have these great accelerations, but somewhere between less than 26 to 28 weeks, we're not expecting these babies to have accelerations. Their central nervous system isn't equipped to do that. It's just immature. It's not that there's a problem. It's just that it's immature. Yeah, they're only 24 weeks. So whatever. Okay, whatever that may be. But in your term pregnancy, your term labors, we want 15 beats above the baseline for 15 seconds. Okay. Now, I don't know if it says it in a later part of this screen. I'm just going to tell you. So if the acceleration is greater than 2 minutes, then it's a prolonged acceleration. And you'll have a lot of those. And I don't write that a lot in my charting, but for an exam, if it's asked on exam or NCLEX, what it is called if an acceleration lasts more than 2 minutes or less than 10 minutes, it's a prolonged acceleration. But in my charting and in normal charting, prolonged accelerations are not really designated as prolonged, they're just designated as accelerations. Then if the acceleration lasts more than 10 minutes, it's a baseline change, it's tachycardia, okay? Oh, if it's above 160, okay? That's for your test, and that's for your NCLEX. If the acceleration is longer than 10 minutes, it's a baseline change. If it's above 60, it is tachycardia. Now, occasionally you'll have these really freaky babies that are just doing somersaults. They're non-stop moving. You may have accelerations greater than 10 minutes. It's like I'm looking at the strip and I'm like, I don't even know what the baseline is. This baby is so crazy, okay? I say that and I'm okay with my baby because I know that, you know, previously my baby was just fine. I can hear this baby moving. Mom's saying, oh my gosh, this baby won't settle down. Everything has been good about this baby. So, you know, I'm not really going to call it a baseline change. I'm just going to call it, you know, sustained, long, prolonged accelerations. Okay, but that's real life. Okay, so not for your exam. For your exam, anything greater than 10 minutes is a baseline change, and if it's above 160, it's tachycardia. All right, so now we're going to talk about decelerations. The first one here in the slide is late decelerations. Late decelerations tell you there's a uteroplacental insufficiency, and those are bad. Okay, there's not good oxygen diffusing to baby, and so this is a problem. We have to fix these. Now, a late deceleration, and we'll see in a picture here when we move on, it happens late in relation to the contraction. So your contraction rises, it gets to its peak, and it starts to return to baseline, and then in that return, that deceleration starts. Now, to the other significant thing about labeling that deceleration late is it takes greater than 30 seconds from the time it leaves baseline till it gets to its lowest point or nadir. Greater than 30 seconds. Okay? It happens late in relation to the contraction, and it takes 30 seconds or more for it to leave baseline and get to the nadir. Okay? Those mean uteroplacental insufficiency. Those are not good. We need to fix those. Early decelerations. These mirror the contraction. I'm sorry they call them early decelerations and not mirror decelerations, but that's the term they came up with, early decelerations. It happens at the same time the contraction happens. It ends at the same time the contraction ends. And just like the late deceleration, the early deceleration takes 30 seconds from the time it leaves the baseline till it gets to its lowest point, which is the nadir. Okay, greater than 30 seconds. Okay. Early decelerations tell us head compression, and you will see head compression as that baby's head descends into the birth canal. As I said in lecture, the baby's bones are not fused, they will mold. That head will compress. So this is a normal physiological response. This is a vagal response. This is what you will see when that head is compressed. You do not need to jump through hoops with these decelerations, okay? You can just maybe monitor the woman a little closer because she might be getting really close to delivery. Make sure your table is set up, make sure your team is ready, and then just wait until she's ready to push. Now, variable decels tell us there's cord compression. Okay, when the woman has a contraction, the uterus is squeezing, the cord might be laying in a position where it's getting compressed against the uterus and the baby's body, and you will see a deceleration that's called a variable deceleration. This is the same thing as someone putting a blood pressure cuff on your arm and squeezing the blood pressure cuff. Your pulse in your wrist will decrease, and then they will release the blood pressure cuff, and then you will feel your pulse return to normal. This is a normal physiological response to cord compression. However, with cord compression, you have decreased blood to the baby through that cord, so oxygenation is going to be decreased. If, you know, baby is just having a few variable decels every now and again, you know, okay. But if this baby is having variable decels with every contraction and mom is contracting every 2 minutes, that's like baby holding their breath for 60 seconds every 2 minutes, and after 6 to 8 hours, well, even sooner maybe, that baby's going to start getting tired, and you're going to start seeing other things in the heart rate that makes you worry about this baby. So a variable decel is abrupt drop from the baseline, and it's an abrupt return to the baseline. They may look like U's, they may look like V's, they may look like W's, and they may look like they have little accels before and after them, okay? When they have little accels before and after them, interestingly, what that is so in the baby's cord, there are 3 vessels, okay? There are 2 veins, and I'm sorry, there's 1 vein and 2 arteries, okay? The vein has all the blood that's running to the baby. The 2 arteries have all the blood that's leaving to the baby, okay? So when, and the vein is the biggest one, the arteries are the smallest one. When that contraction occurs and that cord is being compressed, those little tiny arteries get compressed first. So you actually see an increase in the heart rate when that happens. So that's why you get that shoulder. And then as that vein gets compressed, then you see the deep variable decel. Okay, so that's kind of interesting. And then the variable decel, it's abrupt when leaving the baseline, so it's less than 30 seconds from the time it leaves the baseline to the nadir, okay? And then same with the return. It's abrupt. It's less than 30 seconds, okay? Now that I said that about those 3 decelerations, that's textbook, okay? Those are the correct answers on the exams, on your OB exams and on your NCLEX. Now, when we look at some strips here, we will see that those decelerations don't always fit the definition, okay? So this is where your critical thinking skills are going to come into play. For instance, the late deceleration, it is a late deceleration, but the deceleration total was only 30 seconds. So how can it be termed a late deceleration when the definition of a late deceleration is it takes 30 seconds or greater for it to leave the baseline to its nadir? So not all the decelerations will actually fit in precisely the definition. But look at that deceleration in relation to the contraction. Does it look late? Is it happening late even though it's only 30 seconds long? Okay, so same thing with the variable decel, and same thing with the early deceleration. Oh, sorry, let me press pause. Okay, sorry about that, my dog killed an intruder. So here we go. So I think that was it on the variable deceleration. Now, just like with the accelerations, if your deceleration is longer than 2 minutes, but less than 10 minutes, it's a prolonged deceleration, okay? If it is longer than 10 minutes, it's a baseline change, and it's bradycardia, okay? If it's less than 110, it's bradycardia. So now let's scroll down here and look at a few examples like we did in class. Oh, we didn't even go over this in class. So there's 3 categories of, once you've determined what all your heart rate's doing, there's 3 categories that are important as far as determining fetal well-being. The first category is category 1, that's a normal tracing. So what qualifies as category 1? It's a baseline fetal heart rate of 110 to 160 with moderate variability, okay? That has to be present. Those 2 things have to be present, okay? You cannot have any late or variable decelerations, okay? And you can have early decelerations. You don't have to, you can have. And remember I said early decelerations are head compression and they're okay. So if you have them, if you don't have them, that's okay. But to fit a category 1, your baseline has to be normal, which is 110 to 160. You have to have moderate variability, and you cannot have late or variable decelerations. Category 2 tracing is, and it says here, all tracings not categorized by category 1 or category 3. That is a lot of times how we say which one it is. So let's jump to category 3. Category 3 is abnormal, it's bad, okay? So in category 3, you have absent variability, okay? You don't have minimal, you don't have moderate, you don't have marked. You have absent variability, and remember, with absent variability, your baby is not oxygenated. There's no variations or fluctuations in that heart rate, okay? You have absent variability. That's a requirement, okay? Okay, in addition to absent variability, you have to have one of the following: recurrent late decelerations, recurrent variable decelerations, or bradycardia. You don't have to have all 3 of them. You have to have one of them, okay? Recurrent just means that those decelerations are occurring with at least 50% of the contractions, or greater than 50% of the contractions, okay? That's what recurrent means. Now, sinusoidal pattern we have not talked about, and I'm going to hold discussing sinusoidal pattern with you right now. It is a very rare pattern, and it's a very ominous pattern. So if you have a sinusoidal pattern, you don't have to have any of this other stuff. You don't have to worry about variability. You don't have to worry about decelerations. Sinusoidal pattern is its own thing in itself. It's very bad, and we will talk about that later, okay? Now, so if your tracing does not qualify for category 3, abnormal, or category 1, normal, then it's a category 2. That's kind of easy. And I don't know, there is a huge amount of tracings that are category 2. To have a category 2, you have minimal variability. So if you have a normal heart rate with minimal variability, you have category 2, right? Because category 1, you have to have moderate variability. So if you have minimal variability, you automatically go into category 2, because in category 1 you have to have moderate, and category 3 you have to have absent. So if you have minimal variability, you're in category 2. If you have absent variability without recurrent decelerations, you're category 2. Now go down there and look at category 3. You see that if I have absent variability, my decelerations have to be recurrent. Okay, so if they're not recurrent, that means if they're not greater than 50% of the contractions, then I fall into category 2. Okay, you see that? Okay, same with marked variability. If I have marked variability, I automatically go into category 2. I don't fit into 1 or 3. So you can see those other qualifying events for category 2. So you can refer to this when you're doing your charting and when you're labeling what your tracing is. And so you call doc and you say, if all you want to say is, doc, I have a category 3 tracing, I need you here right now. He will know that your baby is having those things, and he does need to come right away. Okay? So let's scroll down here and look at some tracings. Let's practice these again. And like I said, we will be practicing these in clinicals. We will actually look at real strips, and it'll be super fun. Okay? I'm trying not to scroll fast because I don't want to make anybody dizzy. So here we go. Scrolling, scrolling. Almost there. Here we go. So if we're looking at, the first thing we look at when we're assessing a tracing is our baseline. And I know this is small, and I apologize. So let's not look at anything else here, because this, I mean, you look at this and this kind of looks, oh, yuck. So we're looking at our baseline. So what we want to do is we want to kind of draw a line through the middle of our baseline so we kind of get an average. Okay, so we need a 10-minute strip with at least 2 minutes of continuous tracing. When we've got continuous tracing here, and remember what I said at the end of the class, these dark red lines are 1 minute. Okay, so we've got 1 minute, 2 minute, 3 minute, 4 minute, 5 minute, 6 minute, 7 minute, 8 minute, 9 minute, and I didn't count way back here. So we do have a 10-minute strip here. If we draw a line right through the middle of this heart rate tracing, then we see we're kind of running kind of in the middle of 180 and 190. So we're going to say that that baby's heart rate is, the baseline heart rate is 185. Okay? Now, greater than 160, so we have tachycardia here. Okay? And we're not going to discuss what any of these are decelerations, guys. So we're not going to discuss that right now. We're going to go to the next strip. Okay? And we're going to draw a line through the middle of our baby's heart rate tracing to get the average. We do have a 10-minute strip. We do have at least 2 minutes of continuous tracing. So we've drew a line through here, and that looks like, is that 90? I think that's 90. 60, 70, 80, 90. Yes, I'm sorry. That's 90. I guess I should tell you that each one of these from this line to this line is 10 beats. From this line to this line is 10 beats. Okay, so you can count it off. 60, 70, 80, 90. Okay, so we're going to say, Doc, my baby's heart rate is 90. So that's less than 110, so we have bradycardia here. Okay. Now, so we've determined our heart rate, baseline heart rate. Now we need to determine variability. That's the next thing in assessing your heart rate. Variability tells us oxygenation. Okay, so we've already determined our baseline rate, so now we're looking at variability. And look, this is almost a completely straight line. There are some fluctuations, but this strip is designating a absent variability. Okay, so your baby is not oxygenated here. In this next one, we see that we have a little more fluctuation than the above strip. Okay, just a little bit more, not a whole lot. It does actually look quite the same, but we're going to call this minimal variability. Okay, we have some stuff going on here, and remember, from one line to the next line is 10. So if this were a little bigger, we could see that this is less than 5. Okay, so I know, I'm sorry, this looks a lot like the above strip, but you get the picture. Okay. Now this next strip, you can see from this point to this point up here, back down to this point, back up to this point, back down to this point, all these fluctuations, those are greater than 6 but less than 25. If this strip was bigger so that you could really count this out, you would see that these are greater than 6 and less than 5. I'm sorry, less than 25. Okay? So that's moderate variability that tells us our baby is oxygenated. Okay? So here is a picture you can see from here to back down here. Yes, you do have what looks okay here, but we're averaging over 10 minutes. Look at that. Up, up, down, up, down. Those fluctuations are greater than 25, right? So if this one here started at 120, 130, 140, 150, 160, that's a 40 beat differential. So that is greater than 25. This is marked variability. Your baby is telling you that they are struggling and they need your help. So after we've determined our baseline heart rate, after we've determined our variability, now we need to ask ourselves, does my baby have accelerations? And remember, for the term laboring woman, we want 15 seconds long, 15 beats above the baseline. You will commonly hear that called 15 by 15s. So our baseline is running here, okay? And then we see these big humps. They are less than 2 minutes, because from this dark red line to this dark red line is a minute. They are greater than 15 beats, so 10, 20, 30, 40, so that's greater than 15. And they are greater than 15 seconds. So remember, this is 10 seconds, 20 seconds, 30 seconds. So our baby has lots of those accelerations. So that's great. Healthy babies have accelerations. Sick babies do not. Okay? Now, here's showing you some prolonged decels. So if this red line to this red line is 60 seconds to 60 seconds, okay, so here's your 2-minute window. Here's an so here's our baseline, okay? This is our baseline. And here's those accelerations. And yes, they do drop down. They're not continuous. They can be continuous. But basically, in this 2-ish minutes, this baby has this really long acceleration, okay? So here's another one. This is not quite 2 minutes, but it just comes down briefly. And then here is this big, long, greater than 2 minutes, but less than 10-minute acceleration, because our baseline is down here. Remember how I told you that sometimes my babies are so crazy that I can't determine the baseline? Because I don't have 2 minutes of where the baby is not accelerating. Okay, so sometimes it can be really difficult to interpret these strips. See, here we come down to baseline, but this is only like 10, 20, 30 seconds, you know. So here we only have just less than 60 seconds of baseline. So it can be really hard to determine baselines. But anyways, prolonged decels aren't bad. You've got a very active baby, but if this prolonged decel, I'm sorry, acceleration was greater than 10 minutes, then we have a baseline change. Okay, that being said, you know, you just have to kind of use your critical thinking skills to say, is this a baseline change, or do I have just a crazy baby that's doing jumping jacks and not cooperating much. Okay, so now we're going to talk about decelerations. Here is some pictures of some early decelerations, and these are great because they don't 100% meet the criteria, because they sometimes take less than 30 seconds to get to their nadir, and it makes it very hard to determine what these decelerations are. You've got to look at what the contraction's doing. You've got to look at what the deceleration's doing. So we have a baseline over here, okay? So it's about 150 beats. We can see that, pretty much our baseline is 150 beats, okay? We're not even going to talk about variability, because we're focusing now here on what decelerations look like. So if our baseline is 150 and we have this deceleration dropping here, okay, and then going back up to 150, so when it drops, we draw a line down. Oh, sorry. It pretty much matches when the contraction starts. And when it returns to baseline, it pretty much matches when the contraction returns to baseline. So right now, off the top of our head, we're thinking this is an early deceleration because it kind of mirrors the contraction. But if you were to count this out, 10, let's count down here. So it leaves the baseline right about here, but we're going to round it. So 10, 20, It barely makes 30 seconds, okay? So remember we said the definition of an early deceleration is that when it leaves the baseline and gets to its lowest point, its nadir, it's 30 seconds or greater than 30 seconds. This barely, I mean, you can argue this doesn't meet that definition. And the return back to baseline is really choppy, so this one is a really hard one to determine. But it does happen with the contraction. It does kind of mirror the contraction. We're going to call this an early deceleration. Here's another great example. Like this deceleration, total duration, 10, 20, 30, just over 30 seconds. So it is definitely less than 30 seconds to when it hits its nadir. So one nurse is going to call that what? An early, because it mirrors the contraction, okay? And one nurse might call that a variable because of the definition that it doesn't meet greater than 30 seconds that it leaves the nadir, or leaves the baseline to its nadir. So one deceleration, we're not going to determine our whole life plan, okay? So let's look at the next one. This one's a little better. It's a little slower, 10, 20, 30 plus. So this one really meets the definition. It happens with the contraction, it ends with the contraction, it mirrors the contraction. This is an early decel. So you can see how these are, really interpretive, okay? This one, I'm telling you guys, this one is a variable decel. It's not an acceleration with a deceleration. It's the shoulder that I talked about. Sometimes when you have a shoulder, this is a variable, okay? So thank you, NCC, for throwing that in there and confusing our world. But moving on. So here's late decelerations. So we have our baseline running across here, okay? We have our contraction, starts right here, okay? It starts right here. It gets to the top right around here, and it returns right here. Okay, the deceleration, okay, we can either count this part of it or count it right here. Either way, it starts right there. The contraction has already started. The contraction is at the peak, okay? That's late. Now, this is really difficult to determine how many seconds from the time it leaves the baseline to where it hits its nadir. So that's where I said use your critical thinking. It may not perfectly match the definition, but yeah, look, it's happening late in relation to the contraction. So it's a late deceleration. This baby needs some help. Same thing over here. Here's the start of the contraction, okay? And here's the start of the deceleration, okay? So that's late. They could have used better pictures, I think. So anyways, let's look at these two decelerations, even this third one here. Here's our baseline. Okay. Here's this deceleration, an abrupt drop, an abrupt return. It looks like a V. Here's another one. It looks like a V, abrupt drop, abrupt return. Same. Okay. Let's count from the time it leaves the baseline. Let's say right about here. Let me go down. So 10, 20, 30. So a variable decel is less than 30 seconds from the baseline to the nadir. This one barely meets that definition, but it does look abrupt. It does look abrupt. It's not late. It's not early. Or it could be early. This could definitely be an early. One nurse would say this is an early deceleration. One nurse says this is a variable. Okay, I'm sorry, babies don't always cooperate textbook wise. Okay, this next deceleration, so it leaves the baseline. Let's just say right here at this dark red line. Okay, let's count 10, 20, 30. So that one meets it. Let's count this one. From the time it leaves the baseline is right here, 10-ish seconds. So there you can see how sometimes it can be really difficult to interpret what this deceleration is. You want to look at several decelerations, and you want to use your critical thinking judgment skills here in deciding what's wrong. If you can't tell if this is an early, a late, or a variable deceleration, treat her. That won't hurt her. What will hurt her is if you don't err on the side of caution and you don't treat her. Okay? It'll hurt baby, not her. I'm sorry. Turn this woman on her side. Give her a fluid bolus. Throw some oxygen on her face. That's not going to be wrong. Okay? So if you're undecided or can't figure it out, just go ahead and treat her. Okay? Look at this nasty looking thing. Okay? So we're going to say they're calling this prolonged decels. So that means our baseline is up here in the 155. Okay? This one, who knows what that baseline is, but it's somewhere around 130, and who knows what that baseline is. Whatever. So this was a bad strip to use, but anyways, we would like to see more of our baseline so that we can say for sure prolonged decels. Now, to be a prolonged decel, it has to be greater than 2 minutes but less than 10. If it's greater than 10 minutes, it's a baseline change. Okay? So here we have a deceleration that lasts 1 minute and a half. Okay? Here we have a deceleration that lasts 1, 2, 3, 4, 5 minutes. Oh, poor baby. Okay? Now, if this were not 5 minutes and this were 10 minutes, okay, let's pretend. We're going to kind of draw a line, try to draw a line through the middle of this, or what you think would be the middle of this. And what would your baseline be if this was 10 minutes worth of strip? Well, it'd be about 90. So 90 is less than 110, so that means this would be bradycardia. All right. Now, real quickly, let's forget about the fetal heart rate strip. Let's count contractions. So remember, the dark red line to the dark red line is 1 minute. These little squares are 10 minutes. So we start at the beginning of the contraction and we count 1 minute, 2 minutes, and 10, 20 seconds. Okay? So I would write that when I'm documenting in my chart. I'm not going to say 2 minutes and 20 seconds. I'll say 2 to 3 minutes. Okay? But we're doing an average. Okay? So this contraction starts right here. We're counting 1 minute, 2 minutes, almost 3 minutes. Let's count again. 1 minute, 2 minutes, almost 3 minutes. So I would say that this woman is contracting pretty regularly around 3 minutes. You would not be faulted if you said 2 to 3 minutes, okay? Yes, none of the contractions are exactly at 2 minutes, but this one right here, these two right here, are about 2 minutes and 20 seconds apart, so rounding is fine. How long are the contractions? Well, we count from the beginning of the contraction, 10 seconds, 20, 30, 40, 50, 60, 70, 80 seconds until she gets back to normal resting tone. This contraction is 10, 20, 30, 40, 50, 60. So if I counted all through here, that would probably be about consistent. So I would say she's contracting every 2 to 3 minutes for 60 to 80 seconds. Okay? If she has a monitor on the outside of the body, I would palpate her contractions and say where they were soft, moderate, or strong, or mild, moderate, or strong contractions in strength. Okay? Now, the one thing I didn't talk about in lecture today is, what do you say if she's having too many contractions, and what does that mean? Too many contractions is she's having less than, her contraction frequency is less than 2 minutes. Or in a 10-minute period, she's having more than 5 contractions, right? So if we count here from the start of this contraction to the start of the next, 1-ish. So she's 1 minute and 20 seconds. That's too close. We don't want them closer than 2 minutes apart. 1, 2. So that one's just about 2 minutes. 1, and what's that, 30, 40 seconds? It's just, she's contracting too often. And in a 10-minute period, so here's 1 minute, 2 minute, 3 minute, 4 minute, 5 minute, 6 minute, 7 minute, 8 minute, 9 minute, 10 minute. Let's count those contractions. 1, 2, 3, 4, 5, 6. She's having more than 5 contractions in a 10-minute period. She's having too many contractions. So with too many contractions, her uterus can be harmed, and definitely the baby's not getting a break. Every time she contracts, that squeezes the baby, and baby has trouble getting oxygenation during contraction. So baby's holding her breath every less than 2 minutes. Okay. We define that, or we term that tachysystole. So if you say tachysystole to any OB provider or healthcare team member, then they know that your patient is contracting too much. Okay. So real quick, I know I'm taking a lot of time here. This is a category 1 tracing. Okay. So if you remember category 1, we have to have a normal baseline. We have to have moderate variability. So we look here at our baseline, we draw a line through it, it's about 130, that's normal. Our variability, look, we've got lots of fluctuations here. They are greater than 6 seconds, or 6 beats, I'm sorry. So we have moderate variability. That's the 2 things we have to have, okay? Accelerations are great, but we don't have to have those. What we can't have are any decelerations, and we do not. So this is category 1 tracing. Okay, category 2 tracing. So define category 2 tracing. Well, it can't be category 1, and it can't be category 3. So what we have here is we have a normal baseline. It's at 120. We don't have any decelerations. But what we do have here is minimal variability. Okay? So if you were to blow this up, all these fluctuations, they're less than 5 beats. So that's minimal variability. Now remember, in category 1, we have to have moderate variability, so this doesn't qualify. In category 3, we have to have absent variability. This is not absent, this is not moderate, so this is category 2. Okay? Now, here is minimal variability. Again, here is absent variability, and that's a criteria for category 3, right guys? You have to have absent variability with category 3. But you have to have recurrent decelerations. We don't have any decelerations. So this doesn't qualify for a category 3. This is a category 2 strip. Okay? Okay. This is, as you can see from the answer here, this is marked variability. Category 1 has to be moderate variability. Category 3 has to be absent variability. And we don't have that, okay? We do have decelerations, but we don't have the other things. Yeah, I don't want to talk about this fetal stimulation. Okay, well, that's not what we need to talk about. So you can just review these. Oh my gosh, look at this one, guys. This is bad. Okay, these are bad decelerations. They look ugly to you even, don't they? I want to go see the sinusodal strip. Let's review that. You can look at those things up there. Here's category 3 tracing, absent variability, and we have to have recurrent decelerations with absent variability, okay? And we do, because recurrent is greater than 50% of the contractions, and we actually have a deceleration with every contraction, so we've definitely met that criteria. This is category 3. Okay, now this is the sinusoidal pattern that I wanted to save to last. Look at this pattern. What the heck is this? You can't determine a baseline. You can't determine if there's variability. You can't determine if there's decelerations. You can't determine if there's accelerations. It doesn't look real, okay? It's just these undulating, up and down, uniform, almost undulating deals here, okay? This is called a sinusoidal pattern. They're very rare and they're very critical, and your baby needs delivered immediately, okay? So that's my recorded lecture. If you have any questions, please let me know, and I will see you in 2 weeks.